Today we'll be learning about the hip joint. And for this learning, first I'll have an explanation with the help of sketches. Then I will go on a model and then I will be explaining on the plastinated specimens. For that I'll be using sections as well as real-time plastinated specimens.
Hip joint is one of the very powerful joint in human body, and this is a ball and socket type of synovial joint. Let's look at its different features. We all know the articulating surfaces are the acetabulum and the head of the femur bone. And now we are looking at, let's label this and let's look at what are these structures which are visible to us. So this is the head of the femur, and then we have the neck of the femoral bone. And can you see there is a line, there is a raised area. So this is my intertrochanteric line, and this is my greater trochanter, and there we can see the lesser trochanter. So these are the features which are connected to the proximal end of the femur bone. Now there we can see the pubic tubercle, and then last, there are so many other things, but I'll be talking about only which are connected for the understanding of the hip joint. And this number 7 is the acetabulum. This is the cup where the head of the femur go and get accommodate and to create this one of the very strong spheroidal type ball and socket type synovial joint. This is acetabulum. Now, and this place is the ilium, and which part of the ilium? This depression is known as the iliac fossa. And there we can see anterior superior iliac spine. And now this green structure, that is the joint capsule. This joint capsule surrounds the hip joint circumferentially all around. And then this capsule, which is a fibrous structure, it is strengthened by a number of ligaments. These are extracapsular ligaments, and this Y-shaped thing is my iliofemoral ligament. It's one of the strongest ligament. And then you can see this other one, that is my pubofemoral ligament. Now there is a third one which is known as ischiofemoral ligament, but you cannot see because this is we are looking at the anterior view of the hip joint. So to see that ischiofemoral ligament, we have to go back, we have to look the posterior aspect of the hip joint. So now, they are re-strengthening the capsule, and let's go back. So we are looking at now from the posterior view, posterior aspect of the hip joint. This is iliac crest. We talk about it, anterior superior iliac. This is no more anterior superior. This is posterior superior iliac spine. Anterior superior iliac spine is in front, and this is posterior inferior iliac spine. And this is again the pubis, and this one is my ischium, and this is my acetabulum. Acetabulum is a cup-shaped cavity. And then this number 1 is indicative of my greater trochanter, and then number 2 is my lesser trochanter. And now the capsule we have seen from the anterior view. Now we are looking at this capsule from the posterior view, and then we can see that a little bit of my iliofemoral ligament is visible on the posterior aspect as well. And we have talked about this is one of the strongest ligament. And then this is one which we were not able to see from the anterior view, and this is my ischiofemoral ligament, and this is the weakest one. Now, we have seen the ligaments who are present anteriorly, and we have seen the ligaments who are present posteriorly. Now within how this head of the femur is being going, when it is going into the acetabulum, we are looking at the acetabular cavity, and this is the head, and there are certain features. So let's review them. So this is anterior superior iliac spine, and this green structure is the acetabular labrum. And then inside we can see this surface of the acetabulum, which is lined by the hyaline cartilage, and we call it lunate surface of the acetabulum. And there is a pit which is visible at the head of my femur, and this we call it as the fovea, and one very strong ligament is attached at this place. And there we can see, now this is another ligament of my hip joint, and this ligament is known as ligamentum of the head of the femur. This ligament, through this ligament, we have an artery which runs through it to reach to the head of the femur. That artery is known as, according to its location, the foveolar artery, and that is a branch from my obturator artery. This ligament is an intracapsular ligament. The other ligaments, they were iliofemoral, ischiofemoral, pubofemoral. They were extracapsular ligaments because they were lying outside of this joint capsule. And then the part which is going at this level, it has a different name. It bridges this gap, and we call it has a name, transverse acetabular ligament. And now we can see a real image of a head. You can see this ligamentum head of the femur, and then you can see the acetabulum. Then you can see at the rims, we can see very clearly the acetabular labrum is being visible to us. And now a very important point, the blood supply of the head of the femur. And this is really important, and it has a lot of clinical correlation because femur neck fracture is one of the most common entity, and this head is one of those structure which is vulnerable to go under avascular necrosis. Now first we should look at it, how the different arteries, they are responsible to supply blood to this head of the femur. So now let's look at the pattern of the arterial supply to my head of the femur. And there we are looking at the profunda femoris artery, and this is one of the deep branch coming from my femoral artery, and it's a really important artery. And this artery, it gives so many branches, but those worth mentioning regarding the blood supply of the head of the femur, we have medial and lateral circumflex artery. And now you can see that the medial circumflex artery, which is going behind, going posterior to my neck of the femur. And then they are making a complete circle here, and then we can see anteriorly the lateral circumflex artery, and they are making a complete circle around the neck of the femur. And through these we have branches. I can show you only the anterior one, but there are a big number of these ascending arteries, and these ascending arteries are called ascending cervical arteries. They are a lot from the medial circumflex, and as compared to, there are less from the lateral circumflex. So the medial circumflex artery is the prime artery which supplies blood to the head of my femur bone. And then now we are looking at the ligament of the head, and we have seen it previously, and through this we have talked about the foveolar artery traverses through this, and this artery, you can see it's also going to contribute towards the head of the femur. This artery is well preserved in the early age of the life, and the later part it becomes thrombosed. So if we can see a child in early age of his life, there are a fair enough chances of patency of this foveolar artery, and that will help to save this head of the femur. So in old age, this artery, in adults old age, this artery is not that functional. So if this medial circumflex artery and its ascending cervical arteries, which becomes the retinocular artery, if they are damaged, this head can undergo avascular necrosis, and this is one of the very serious complication which is occurring from this injury to the neck of the femur, and in particular intracapsular part of the neck of the femur. We'll be talking about it shortly. So now let's look at an X-ray. So right now I'm showing you an X-ray, and what are we looking at? We are looking at the head and the neck of the femur bone. And then you are looking at, with this yellow color, the acetabular cavity, and they are making this cup and ball and socket type of joint called the synovial joint. And we can see the articulating surfaces, and they are congruent to each other. And then a very important landmark, if I'm looking at, if somebody has a fall and I'm suspecting a fracture of the neck of the femur, what is one of the there are various criteria, but I'll be talking about one major point which which should not be overlooked, and you can see this with this yellow color. You can see there is an arc has been made, and this is a Shenton's line, and you can see that there is no break in that. So this is one of the factor, if we can see, we should look for when we are evaluating an X-ray where we are suspecting the fracture to the neck of the femur. We should look for the integrity of this Shenton line, and if it is normal, it means the things are safe and patient has survived, the neck of the femur has survived from the injury. Now look in this one. Let's look at this Shenton line. So the journey has begun, but no, there is a breach. I can see that. So my Shenton line is not normal. And then I can look at, so this is going away. It's not making an arc. This arc is broken. So this is the Shenton line is lost. And if I look at the neck of the femur, I can very clearly see the overlapping neck, which is going above, and that is indicating the fracture occurring as the intracapsular part of the neck of the femur bone. So now let's look at, you're looking at a normal bone. So if we have a fracture occurring at the neck of the femur, so as a result, we have talked about the patient can have avascular necrosis, and this is an intracapsular type of fracture. And what is the treatment? We have to replace this head. If we leave this head and if we repair the artery, but there are fair enough chances of complications, so it is replaced by an prosthesis. A metallic head has been placed, and you can see how it is. This X-ray is showing you how this fracture head of the femur has been replaced by this metallic prosthesis. Now, another example, if the fracture line, it corresponds to it runs in between the two trochanters, so we call it intertrochanteric fracture, and this fracture lies out of my capsule, so this is an extracapsular fracture. Now my treatment plan will be different. So now we can put this dynamic hip screw, and as in this case, there is no damage occurring to my retinacular arteries, which are branches from my medial primarily and the lateral circumflex femoral arteries. There are other ones who are also contributing, but the medial circumflex femoral is the prime artery. So now they are not damaged. So now we are not bothered for the vascularity pattern of the head of the femur. So we can replace it by this dynamic hip screw, and that you can see it's been placed, and then everything can go fine.
Let's look at a real specimen of the hip joint. And we can see here very clearly the hip bone or the coxal bone and its different salient features, which we have already discussed. And you're looking at the proximal femur. Greater trochanter is very easily visible to you. And there you are looking at the capsule from the front. And then when we turn it around, you can see this capsule from the back. Now, with the help of this model, you can see very clearly this ligament which lies anterior to my hip joint, and this is, you can see there's a gap here. This is a Y shape, and this is coming from my ilium to the femur, so we call it iliofemoral ligament, and this is the strongest ligament within my hip joint. After this, you can see underneath, in between this gap, capsule is visible to you. And then one which is coming from my pubis bone coming to the femur, and that is my pubofemoral ligament. So two of the ligaments are nicely visible to you. One was iliofemoral and the other one was pubofemoral. Now to see the ischiofemoral ligament, we have to look from the posterior aspect of this hip joint. And there I'm sure you can see a little bit part of my iliofemoral is visible, but this one which is going from the ischium towards my femur, this is my ischiofemoral ligament, and this ligament is the weakest ligament among the ligaments of my hip joint. There are two more ligaments which I cannot show you on these given models, and these ligaments are one which is attached to the head of the femur, and other one is the transverse acetabular ligaments. They have already explained within presentation part. Now we are looking at a section at the hip joint region, and what I'm using here, I'm using a plastinated model, and this section is a frontal or a coronal section, and very easily you can all identify this is the head of the femur, there is the neck, and that is my shaft of the femur. And there you can see this head, it's going very clearly within this cup, and this cup is my acetabulum. And there you can see the ilium bone, and then rest of the things are here are the muscles who surround this joint. This is another slice of the same section, just to show you some of the more features. You can see very clearly the head of the femur, the neck of the femur, the greater trochanter, and the proximal shaft and the acetabulum.
So now let's recap. My hip joint is a synovial ball and socket. Articulating surfaces, we know about that, the acetabular cavity and the head of the femur. Capsule is a very strong fibrous structure, and then we have talked about a number of ligaments. Iliofemoral, the strongest, pubofemoral, and the ischiofemoral is the weakest. And then we have seen the ligamentum teres, a ligamentum of the head of the femur. And then we have seen the transverse ligament of the acetabulum, and the stabilizing factor, the shape of the articulating surfaces. And the muscles and the ligaments who are surrounding whole of this area, they are one of the major factor in the stability. And what movements are possible at this hip joint? The movements are primarily flexion extension, abduction adduction, and medial and lateral rotation. Now, when someone has fractured his neck of the femur, there is a very classic pattern of one can observe when we are examining the patient. You can observe the shortening of the limb, laterally rotated leg. This is classic of neck of the femur fracture. And if someone has posterior dislocation and anterior dislocation, posterior dislocation is the most common. Around 90% of the people, if they have this posterior dislocation. So in this posterior dislocation, the structure at risk is my sciatic nerve, because it's lying most posterior to when the head of the femur goes out of the acetabulum and going posteriorly. So the sciatic nerve is at risk, and sciatic nerve is the prime nerve which controls my lower limb, is one of the major contribution for my lower limb. So one should be suspecting that. And remember, in the posterior dislocation of the hip joint, the posture is the leg of the patient will be appearing to you. There will be shortening. Yes, there will be shortening, but there will be adduction and medial rotation. And then anterior dislocation, it's only occurring in 10% of individuals. Thank you for your time.